An anorectal malformation happens when the anus, rectum, and other organs do not develop properly during pregnancy. This affects the child's ability to have bowel movements. The anus is the opening at the end of the rectum where sphincter muscles help to control the bowel movements. The colon, rectum, and the anus work together to move stool out of the body. During a bowel movement, stool passes from the colon to the rectum and then out of the anus. But when the child has an anorectal malformation, stool can't leave the body until surgically corrected. Each child's malformation is unique and can range from mild to severe. In mild cases, the opening may be too narrow and in the wrong place. Usually, these children can have voluntary bowel control after surgery. In moderate cases, it may not be present at all, preventing a baby from having a bowel movement. In more severe cases, the rectum opens into the urinary or genital urinary tracts, which can cause a urinary tract infection. Some of the children may not achieve normal bowel control. An anorectal malformation affects girls the same way as boys. The rectum can be in the wrong place, missing, or connected to the genital urinary tracts. Some children may only need one operation to correct their malformation, but mostly need 3.
So, what is anorectal malformation? So, anorectal malformation, or what we call the ARMS, are a complex group of congenital anomalies involving the distal anus and rectum, as well as the urinary and genital tract in a significant percentage of cases. So, the prevalence is approximately 1 per 5,000 live birth. Incidence is 1 in 2,500 to 1 in 4,000 live birth. So, with a slight male preponderance in most ARMS, the anus is not perforated and the distal enteric component may end blindly or as a fistula into the urinary tract, genital tract, or upper perineum. So, the anorectal malformation are associated with other congenital anomalies in up to 70% of cases. So, the final prognosis and quality of life for children with ARMS will depend to a large extent on the presence and gravity of these associated anomalies by the Alamo et al. 2013. So, yung anorectal malformation is a widespread disease which happen pag yung anus, rectum, and other organs ng isang bata ay di siya na fully developed during the pregnancy. So, that's why nakaka-apekto siya sa bowel movement ng mga bata. Kaya pag merong anorectal malformation yung isang bata ay yung kanilang stool ay di nakakaalis sa kanilang katawan until the surgery is corrected. So, each child na merong malformation, anorectal malformation, yung defect na meron sila ay can range mild to severe. So, in mild cases, yung opening ng anus ng isang bata ay nag-narrow and in wrong place siya. In moderate cases, it is not presenting at all. In more severe cases naman, yung rectum ng mga bata is nag-open siya sa urinary or genital urinary tract, which can cause urinary tract infection. So, this condition affects boys and girls because yung rectum ay in wrong place, minsan nawawala or nag-connect siya sa genital urinary tract.
Moving on to the pathophysiology and causes of anorectal malformation. Here we have several epidemiological studies that had assessed the association between 7 prenatal of parents that have been suggested to be environmental risk factors for anorectal malformation. And these risk factors were identified as smoking, alcohol, caffeine, illicit drugs, overweight or obesity, diabetes, and occupational, based to the study conducted by Green, Dinetsky, and Brenner of 2011. So aside from environmental risk factors, we have also three biological factors that cause the anorectal malformation. And one of these is it is an arrest in embryologic development of the anus, lower rectum, and urogenital tract of the sixth week of embryonic life. However, cause is unknown. Approximately 40% of infants with anorectal malformations have associated major anomalies including the Down syndrome and also the Vaxil syndrome or the VACTERL syndrome, which are mnemonic for V, vertebral anomalies, A for anal atresia, T is for the cardiac malformation, C is for the tracheo, and E is for the esophageal fistula, R is for renal, and L is for the lymph anomaly. We also have congenital heart disease, renal abnormality, cryptorchidism, esophageal aplasia, malformation of the spine, and also variant of infantile hemangioma occurring in the extremity. And lastly, among the three is the abnormal development of the terminal hindgut, ranges from the mild anal stenosis corrected by simple dilatation to complex deformities such as rectal aplasia and fistula with varying degrees of fecal and urinary incontinence. And also, BMP4 and Hope genes may play a role in the formation in the cause of the anorectal malformation.
So now let's proceed to the assessment findings. So these are the assessment findings we found in anorectal in a patient with anorectal malformation. So first, we have the absence of anal opening. Stimulation of perineum can lead to puckering and then displace of anal opening. The anal opening near the vaginal opening in female, and the patient has the thermometer, small finger or rectal tube cannot be inserted into the rectum. Also, the patient has the sign and symptoms of meconium stool is absent or delayed. So, it means that the newborn has a failure to pass the meconium within 24 to 48 hours. Also, the stool passed by way of the vagina or urethra may appear as green thin urine, and the patient can experience progressive abdominal distension, and the fistula is likely to be present. So, we can identify if the fistula is likely to be present in a patient with anorectal malformation dahil makaka-experience yung mga newborn ng skin irritation around their anus, and also makaka-experience yung mga patient ng smelly discharge from near their anus and passing pus or blood when they are going to poo, and swelling and tenderness around their anus. And lastly, the patient may experience vomiting if the infant is fed.
After we have learned about the clinical manifestation or the assessment findings on anorectal malformation, then we are now ready to learn about the diagnostic test on arm. According to the study conducted by Alamano et al. Of 2013, imaging studies play a key role in evaluation and classification of anorectal malformation or arm. In neonates, clinical and radiologic examinations in the first 3 days of life help determine the type of ARM and the need for early colostomy. In older children, preoperative pelvic magnetic resonance imaging or MRI is the most efficient diagnostic method for evaluating the size, morphology, and rate of development of the sphincteric musculature. Aside from radiologic examination and magnetic resonance imaging or MRI, we also have urine examination for the presence of meconium, and the lateral degrees will indicate the presence of a fistula. Transfibulateral abdominal X-ray infant in a prone position with pelvis elevated was also used as a diagnostic test for identifying or um, for identifying and assessing the degree of the anorectal malformation. Thus, in the blind rectum gives a radiolucent image, and the measurement from the skin or the radiostate marker in the blind rectum allow an estimate of the height of the defect. Also, abdominal ultrasound to detect a urinary obstruction and locate rectal pouch was also utilized as a diagnostic test. And lastly, Boyding cystourethrogram to detect commonly associated urinary tract anomalies such as urethral reflux. And now, let's discuss the medical and surgical management for anorectal malformations. And then one of the medical and surgical management we can do is the membrane excision. So for example, in the imperforate anal membrane, so the internal and external sphincters muscles or yung sphincter muscle na nagkocontrol sa bowel movement are intact. So usually requires only a membrane excision or yung pag-alis ng membrane sa anus ng isang baby from the anal opening para lang magkaroon ng labasan yung stool ng isang baby. So, repaired at birth, kaya no colostomy required. So, we have also anastomosis. So, like the membrane excision from the imperforate anal membrane, so ang anastomosis is yung pag-dilate naman ng anus ng isang baby kasi nga stenosis means narrowing. So, merong narrowing sa anus ng baby. So, in anal stenosis, internal and external sphincters are also intact. So, usually treated with anal dilation and pagbuka sa labasan ng stool sa anus ng isang baby. So, occasionally requires myotomy or cutting of anal muscle para hindi siya para ma-relieve yung narrowing or stenosis sa anus. And then treated at birth, kaya no colostomy required. So like the imperforate membrane, so the imperforate anus or the anal agenesis, which in other term, anal agenesis means the failure of the anus to develop during the embryonic growth. So under the imperforate anus, no lesion is included. So can usually be repaired with perineal anoplasty or the reconstruction of the anus, which creates an anal opening for passage of stool, usually accompanied by fistulas that need to be closed at the same time. So by this perineal anoplasty is ma-widen na yung narrow or imperforate na passageway ng stool. Kaya through this is napapalabas yung stool ng baby. So, repaired at birth, colostomy is usually not needed unless a fistula is present or more time for healing is needed. So, colostomy, hindi siya kailangang gawin sa baby at this kind of classification of anorectal malformations since mako-correct din yung condition ng baby ng surgery pa lang. And then, kung meron talagang fistula, which is an abnormal parang tunnel, then kailangan ng gamitan ng colostomy. So, a while ago, we talked about the procedure or surgery done to imperforate anus that is within the low lesion. So, it is called the perineal anoplasty or the reconstruction of the anus. In this, we will going to talk about the high lesion, at which it requires more extensive surgery because of missing innervation. Usually requires a 2-stage procedure, occasionally 3-stage if complex defect is present. So according to our research, there are 3 stages to correct the anorectal malformations, and which includes the first stage, which is the colostomy. Colostomy. Second stage is the PSARP or the pinya procedure, and last stage is the closure. First step is the colostomy, at which the surgeon will split the colon into two endings. So tapos in two endings, is ipapadikit sa abdominal wall ng baby, forming two openings, at which ito-place yung bag sa stomach ng baby para, or sa labasan ng abdominal wall ng baby para salugin yung stool na pinoproduce ng baby. So, and then the second step is anal repair after few weeks rather. Colon or rectum anastomosis, possible colostomy closure. So, posterior sagittal anorectoplasty, also known as the pinya procedure, after surgeon who developed it. So, pinya procedure was created by Alberto Piña, a director in the International Center for Colorectal Care. So the rectum is pulled down and thrown into a newly made anal opening in the perineum. So most surgeons wait 4 to 6 months to complete it to allow for growth. So third step is colostomy closure if the defect is complex and more healing time is needed. So this procedure, hindi na siya yung 3-stage ng correction for anorectal malformation is hindi ginagawa within that week or a month kasi nga DAT yung pasyente. So first step is colostomy, then after few weeks, then yung second stage which is yung PSARP procedure or pinya procedure, and then after 2 months later after prior to the second procedure, then that's the time na gagawin yung third step, which is yung closure ng colostomy at yung pagdikit ng colon na hinati sa dalawa.
So the next for the medical and surgical management is the complex fistula and cloaca. First, we have the complex rectal, urologic, and vaginal reconstruction are necessary. So first, we have the complex rectal. So in this procedure, yung skin and muscle sa labasan ng poop sa anal ay kinakat upang ma-convert siya sa another na labasan up to open groove. So this allows the fistula to track and to heal from the bottom up. In the case of a more complex fistula, the surgeon may have to place a special drain called seton, which remains in place for at least 6 weeks. In urologic surgery naman is the integration of surgical activities for the pelvis, the colon, urogenital, and gynecological organs, primarily for the treatment of obstruction, dysfunction, malignancies, and inflammatory diseases. Sa vaginal reconstruction, ito yung procedure na yung vagina ng isang babae na parang nag-loose na siya due to aging or childbirth. Ito yung surgery na ginagamit upang muling sumikip, and the surgery aims para ma-reduce ang pain, tas ma-improve ang appearance, size, function, and possibly the sensitivity of the vagina. So the second one is the urinary diversion is performed in the neonate if a urologic emergency is apparent. So note that the rectal dilatation may be needed for any condition after the final surgery. So yung urinary diversion is also a surgical procedure na gumagawa ng new way sa ihi ng isang tao na lumalabas sa katawan ng tao, lalo na pag yung ihi ay na black or merong kailangang ma-bypass na disease sa area, sa urinary tract, since yung urinary tract ng isang tao is our body's drainage system for removing urine, so which is made of waste and extra fluid. So our urinary tract is designed to have the urine flow from the kidneys through the ureters to the bladder and out of the urethra. So pag yung ihi ay di dumadaloy ng normal, so it may build up into your bladder, ureter, or kidney. So yung ma-build up ng ihi ay nagkakos siya ng pain or urinary tract infection, urinary stone or calculi, and the damage to your urinary tract or kidney failure. So if left untreated, build up of urine in the urinary tract can be life-threatening.
And now, let's proceed to the nursing interventions that the nurse must perform before and after the surgery. So, now let's proceed to the nursing intervention. First is maintaining stability before surgery. So under this, first, maintain NPO status or nothing by mouth. Note any vomiting and note for color and amount. Rationale, nothing by mouth is usually prescribed as a safety precaution. Patients were asked to not eat or drink for a few hours before the operation, or the guardians are asked to not let their patient eat before the surgery. Before the operation, the patient will usually be given antibiotics to prevent infection. Patients may have them as an injection or tablet. Also, NPO, nothing by mouth, prevents patients to be nauseous. Second is minimize energy expenditure due to altered nutritional status. Rationale, to conserve optimal health condition as much as possible in preparation for the surgery. And then third, maintain nasogastric tube fast to decompress the stomach as ordered. And then measure the abdominal girth. So rationale, to hasten the return of bowel function, and inserting a nasogastric tube enables the nurses or the physician to drain gastric contents, decompress the stomach, or introduce passage into the intestinal tract. And then, if distension occurs, measure abdominal girth daily to monitor changes. Fourth is observe the patient carefully for any changes of distress and report. Check vital signs frequently. Rationale, attentive assessments to help to identify the areas or needs of the patient that may seek further attention and support from either physician or parent. Also, comparing previous and current vital signs helps to determine the health status of the patient. Then fifth is use an isolate or radiant warmer to maintain temperature stability. Rationale, isolate or radiate warmer are device help to maintain the body temperature of the body and limit the metabolism rate. Also, it increases convective and evaporative heat loss and insensible water loss. So we have three remaining nursing intervention under maintaining stability before surgery. So number 6 is minimal handling. So cluster procedures together to encourage rest and sleep. Rationale, a sick child deteriorates with handling and distressing procedures. Thus, minimizing handling will promote comfort and rest of the child. Number 7, keep the fistula area clean. So to prevent UTIs or urinary tract infection. And lastly, administer good oral care. So effective and routine mouth care are necessary for hospitalized patients as it helps to maintain the health of the oral cavity and overall health. And now, after performing the maintenance stability before surgery, we will now proceed preventing infection of tooth life. So, first, following anaplasty, do not put anything in the rectum. Position the infant for easy access to the perineum for cleansing and minimal irritation to the side, such as placing inside the his or her abdomen, possibly with hips elevated to prevent pressure on perineal surfaces, and then turn side to side. So rationale, after the anaplasty, the mucosa can pull up into the perineum, causing local irritation owing to excess mucus secretion. And then expose the perineum to air. Observe incision site for redness to reach for healing. The fresh air helps the area to heal faster as it dries the area better. So, and then apply antibiotic ointment to the perineum as directed to treat minor wounds and to help prevent or treat mild skin infections. And then second, following colostomy, observe wound and stoma for redness, drainage, and for healing to identify and report any signs of infection in the area. And lastly, administer IV antibiotic as directed, usually 2 to 3 days. Rationale, antibiotics help to prevent infections at the surgical site. And then we should maintain fluid and electrolyte balance. And under this, we have the 6 nursing interventions. First is monitor for return of peristalsis. Nasogastric tube may be discontinued by the healthcare provider when bowel sounds present. So, rationale, the tube usually remains in place until normal bowel function returns as evidenced by normal bowel sounds on auscultation and or when the patient passes status or nagutot na yung patient. And then second is start oral feedings as ordered. Anoplasty usually within hours. Colostomy when bowel sounds are present and colostomy has output. So rationale, to restore and preserve the nutritional health status of the patient. And thirdly is monitor parenteral fluids and discontinue when oral intake is sustained. So after the surgery, the immune system is extremely weak, thus increasing the chances of an infection. Water helps keep these infections away and acts as a catalyst to the patient's recovery. Furthermore, water helps the body get rid of toxins from the anesthesia. And then fourth, report vomiting. Sometimes anesthesia can make you feel sick. Vomiting is a common side effect and often doesn't last long. And then 5, describe stool frequency, consistency, and character. Report blood in the stool or lack of stool output. So after colostomy surgery, stool may look different than it did before surgery, but should tend to still be fairly formed. Normal stool frequency of at least 1 bowel movement per day in the first 2 weeks is considered typical. Healthy formula-fed baby poop is typically a shade of yellow or brown with tasty consistency that is of peanut butter-like appearance. So breastfeed newborns usually have CD, loose bowel movements that look like light mustard in character. So as a nurse, we should be informed about the normal consistency and character of poop based to their age. So, and then lastly, number 6, monitor urine output, particularly important with urethral defects, including the cloaca. So, urine output is closely monitored after surgery. Urethral defects are the most formidable technical challenges in pediatric surgery. Patients with local malformations may have abnormal development in another organ system. This abnormality may cause spine or vertebral or cause anorectal malformation, heart defects, or renal limb abnormalities.
Next, we have the strengthening coping intervention. So first, assure the parents that colostomy is temporary unless complex surgery is performed. The colostomy is usually closed about 2 to 3 months after the main repair. Next is encourage the parents to participate in the care of the child and to provide emotional security for the child. So the parents have a key role in the healing process of a child, and encouraging the parents to participate willingly in the care of the child will surely boost the child's moral and recuperation process. So next is provide a thorough teaching program for special care needed at home. So it includes a colostomy care and anal dilatation to prevent a stricture at the site of anastomosis from scar tissue after instruction by a healthcare provider. Next, initiate referral to a community nurse, especially if the parents are particularly anxious about the caring for the child at home. So, it ensures the parent that their child receives the best possible care that a community nurse could provide. Next is encourage the parents to talk about their concern. It enables the physician or the nurse to identify underlying concern within the health management of their child. Also, verbalization of concern will help to validate observation made by the nurse during the nursing assessment. So the next one, enlist the help of interactional nurse specialists before the child leaves the hospital and for continued home care needs. This is to provide an easier contact to the interactional nurse specialist for continued home care needs, and then assist the breastfeeding mother to maintain milk supply and provide nutrition to the child. And then also maintain GT or NG tube decompression until the peristalsis returns. So the tube usually remain in place until the normal vowel function return as evidenced by the normal vowel sound on auscultation and or when the patient passes plateaus. So if a bladder catheter is used, provide care as directed and measure the urine output accurately. The urine output is easily measured through the insertion of an indwelling Foley catheter and connection to a urometer. So the daily output of the urine output is 400 to 500 ml of urine is required to excrete obligatory nitrogenous waste. And then observe carefully for the abnormal distension, bleeding from the perineum and respiratory compromise, and also report it immediately. So to have a prompt identification of the post-operative complications which are necessary to avoid significant patient morbidity. And lastly, carry out perennial care to prevent the infection.
Then, now let's proceed to health teaching. First is review special care and procedures to be continued at home. Involve parents and other caregivers in teaching. Advise parents to make daycare providers, teachers, and school nurses aware of child's needs. And then it is important that the family understands the rationale and technique for anal dilation, as indicated by the surgeon. Provide written instructions and assess their understanding of the procedure. And then help the parents to understand situations that may be encountered as a result of anorectal malformation repair as the infant gets older. So fecal impaction due to lack of sensation to defecate, future surgery if the primary repair was not done or the defect is complicated, and that the toilet training may be delayed especially after a full two procedures, and inability to control fecal seepage from the right. And then the last, offer practical guidance to help parents cope. Fecal control may not be achieved until age 10. However, about 85% of children achieve normal or socially acceptable continence if the defect is limited to the imperforate anus or the low lesion. So if incontinence occurs, anorectal manometric evaluation in the post-operative period can give more realistic information about future incontinence. Encourage bowel habit training or patterning of defecation, such as after breakfast. And then promote diet modification. Teach foods that produce laxative effects, such as plums, prunes, chocolate, nuts, and corn. And then add foods that have a binding effect, such as the peanut butter, hot cereal, and then cheese. Stool softeners or anti-diarrheal medications as ordered by the healthcare provider. And then rectal inertia may cause fecal infection, and the rectosigmoid colon is boiling from fluid overflow. The Sacodil suppository or cleansing enema provides assistance in the management. And then after the surgical management and nursing intervention, our expected outcomes that should be seen to the patient and to the family are as follows. First is vital signs stable, should have a stable abdominal girth, and no signs of infection of the sutured line. Also, the skin intact surrounding ostomy, and then nasogastric tube should be discontinued if the bowel sounds are present, and then oral feeding are tolerated by the patient without vomiting. And lastly, the family discusses plans for home care with an enterostomal therapy.